Hey, there we go. And sorry, one more time. I'm just going to say we have Stacey Lee here today to do the presentation. She's a PhD candidate at Dalhousie University in Nova Scotia. And she is going to walk us through an overview of pancreatic cancer. And then at the end, there will be a quiz that we'll go over. And then you can do the quiz if you'd like to. So yeah, with that being said, I'll hand it over to you, Stacey. Thanks so much for being here today.
Great, thank you so much, Erin. I'm just going to share my screen with you guys. You have to let me know if you see it or not.
We can see it.
Perfect. I'm gonna slide back to the top. Okay. As Erin said, my name is Stacey Lee. I am a PhD candidate here in Halifax at Dalhousie. I'm originally from Cape Breton, but moved here about 6 years ago to start my graduate degree. I am studying pancreatic cancer, but I am not, the forerunning expert on it. But I'm here to sort of give you guys a quick intro. I am the first in this series, so lucky for you. It can only go up from here, and I'm sure you will learn quite a lot over the next few sessions. Right. So I'm just going to start going over some of the learning objectives for this that Christ Cause has set out for this talk, and then I'll sort of go through my talk that you'll hopefully hit on most of the things you should take away. One sec, I'm not sure if it's letting me control. There we go. All right, so the first learning outcome is just getting a basic understanding of the pancreas. Identifying where it is in the body and what it does normally, and hoping with the hope that will help understand why we see some of the things we see with pancreatic cancer, some of the symptoms, and some of the reasons why it can be difficult to identify and treat. With that, I'll do sort of a brief overview on both cancer itself and then pancreatic cancer, just to understand, why it develops, how it develops, and why it can be so difficult to diagnose, as well as understanding some of the symptoms and risk factors. I'm sure this is the sort of things you guys are very familiar with, probably even more so than myself. But I'll just give a quick, brief overview and sort of put it in the context and the lens of what we've learned previously about how the pancreas works in pancreatic cancer, along with understanding some of the genetic links, again, which sort of explains why some of the things we see with cancer are there. So as I said to begin, we're going to kind of start with a very basic understanding of what the pancreas is. I'm sort of approaching this talk with an idea of, if you're coming from a perspective of maybe not knowing a lot about this. So I do apologize to the people who have had to sit through a lot of science classes in their day, and maybe have gone over some of this stuff. But I want it to be as sort of approachable as possible. And so the pancreas is a really important organ of the body. It's not one we necessarily always think about. It's not like the heart where you're always kind of, aware of it and wanting it to work as well as possible, but it is really one of those key organs that keeps us functioning. And it's an organ that has two really important roles, both in digestion and blood sugar regulation. And I'll go a little bit deeper into those throughout the talk. But the pancreas itself is found in sort of the upper abdomen. It's like a sort of a long organ, and I found it described as I was sort of putting this talk together, that if you were to put your thumb and your pinky finger of your right hand together, and then align it over the midline of your abdomen with your fingers pointing toward the left, that sort of gives you an idea of where it is in the body. Um, and so it's just behind the stomach in front of your spine. And it's like a relatively smallish organ. Again, another cool thing I found, apparently it only weighs about a deck of cards, the same amount of a deck of cards. So it's not necessarily a really big organ, but it has a really important role. Along with being close to the stomach, it's also close to the small intestine, gallbladder, and liver, all things it works with to sort of help aid in digestion and the regulation of blood sugar. Along with the position, the pancreas is often divided into sections. Again, these are sort of terms that you guys may have heard sort of in the context of pancreatic cancer, but it's largely broken into the head/neck, the body, and the tail regions. And those one have a role in where it's situated, but also can also have a role in how the cancer might be diagnosed or treated, which we'll talk about a little bit later. And largely the function of the pancreas, as I said, is to aid in digestion and to regulate blood sugar levels. Because of these functions, it has a couple different specialized cell subsets that it uses to execute these functions. And when it comes to digestion, we have these acinar cells that make up about 90% of the pancreas tissue. So the largest sort of output of the tissue is to produce digestive enzymes that are really important for breaking down food. So it produces enzymes to help break down fats, carbohydrates, and proteins. And as I said, these are produced throughout the pancreas. They travel down the pancreatic duct, meet up with the bile duct right sort of at the first section, the duodenum of the small intestine, where the real breakdown of food and the processing of those sort of nutrients we get from food begins as it leaves the stomach. And so, sort of along this duct that you'll start to have some of the problems associated with pancreatic cancer. Um, as I will talk about later, but that's its largest sort of like tissue functioning is the development of these digestive enzymes that are important for breaking down food. As I said, the other key role the pancreas does, and honestly, the role most people are familiar with, because this is the role that we sort of get the most sort of pathology with, is its role in blood sugar regulation. So, two of the key hormones it produces and releases that helps with that is insulin, one we've all heard about a lot and we're very familiar with, that plays an important role in lowering blood sugar. And then its opposite, glucagon, which is really important for raising blood sugar when your blood sugar starts to drop. To do that, they have these little pancreatic islets that are found throughout the pancreas, made up of two different cell types, the alpha and beta cells, that produce these hormones. And as I said, this is sort of the role we really closely associate the pancreas with, because a lot of us are familiar with diabetes, both type 1 and type 2, and likely know, either within our own lives or people within our lives, the impacts of diabetes. Um, and so despite the fact that, a small portion of the pancreas does this, it's really one of the most important roles it does and the one we're really familiar with. So that's sort of just a quick overview of the pancreas, and I'll help us sort of situate, um, both today and then hopefully going forward, why, sort of developing the cancer of the pancreas can impact a lot of this functioning. And then, as I talk about later, why sometimes, we have this late symptom presentation, associated both with its position in the body and sort of the functioning it does and the way it's sort of able to work around the development of some of these tumors for a very, very long time. And so the big question, of course, is what is pancreatic cancer? I have this in quotes because I took this directly from the Craig's Cause website, and so this quote cannot be attributed to me. But we really define pancreatic cancer as the development of abnormal cell growth in the pancreas, and that forms a tumor. And a tumor itself is known as an abnormal growth of tissue in any part of the body. And so you develop, these sort of conglomerations of cells that, one, are growing out of control, taking a lot of nutrients, and then can lead down the road to sickness and pathologies as it really starts to impact the functioning of the organ it's in and the organ that's around it. But when I was putting this talk together today, again, knowing that I was going to get people from all different courses of knowledge of cancer, of their journey within cancer, I sort of took a step back and thought, well, if I was explaining this to my dad, who has no scientific knowledge, and really, like, cancer to him is this big black box of scary things that he doesn't understand and doesn't understand why it happens, what would I want to take away from sort of an intro talk that should help you guys going forward? Um, and so we're going to take a step back from pancreatic cancer specifically, and in general, talk about why pancreatic cancer and why cancer in general occurs. So again, big apology to the people who had to sit through a lot of cell biology classes. Um, this is stuff you guys have heard probably a lot, but in order for our body to function and continue and for us to live hopefully long, happy, productive lives, our body cells always have to be replaced. They only last for so long. It depends, differently based on the organ, but they have a lifespan just like anything else. And so to be replaced, they have to replicate themselves and split off through a process known as mitosis, into two daughter cells. In order to do that, the cells have to basically copy themselves, right? They have to take their DNA, they have to really almost photocopy it so that they can split off into these cells and retain all the information they'd had throughout their lives. And this is sort of where we run into the problems that, develop into cancer, because what are they copying? Well, as I said, they're copying their DNA. DNA is the blueprint of our lives. It tells our cells everything. It is the reason we have the color, our eye color, our height. And it also comes with things like susceptibility to diseases. You know, it defines who we are as people in many, many ways. And so for every cell that replicates, it's got to take this information with it. And we have a lot of genes. You know, they estimate between 20,000 to 25,000. And that's a lot of information to be copying, especially in, you know, relatively short periods of times when you consider, you know, the cells themselves. And so every time our cells copy itself, a blueprint must be copied as well. But unfortunately, or I should say fortunately, I guess, you know, our cells have developed these mechanisms over time, but they're not quite as perfect as a photocopier, right? They don't put it on it, hit the go button and get an actual perfect copy. It's sort of more like in the old timey days before the Gutenberg press was developed, and they used to have to copy out books by hand. You know, you'd have these monks in these monasteries copying out hundreds of pages of books, taking them, you know, days and months and whatnot. And so with that, because it's sort of a by hand process, you can sort of start running into problems. And so mistakes happen, right? As the DNA is replicated, you have an error rate every one in every 10,000 letters, or DNA base pairs as we know them. And as I said, we have a lot of genes, a lot of DNA, a lot of base pairs. Um, and so you can average about 690,000 errors every time a cell is copied, which again, that's a lot of mistakes, right? Why, with that in mind, are we not all developing cancer all of the time, right? You would think all of our cells, you know, by the time we were 10 years old would suddenly be so riddled with mistakes, they'd be non-functional. But because DNA knows, you know, and the cells know they're going to make mistakes, they have repair mechanisms that catch most of these mistakes, sort of like a spell check system that you might have, you know, as you're writing that like frantic essay at 2 a.m. that you can quickly go through and identify the problems. So, as I said, most of the time these mistakes can be caught. And depending on the mistake, it doesn't, even if it can't be caught, it doesn't necessarily matter, right? So some mistakes, some mutations, can be mutations that are irrelevant to how the gene functioning is, right? So if you read these two sentences, right, a cell should stop growing every 2 cycles, or a cell should stop growing every 2 cycles. Obviously, the words are different, but if you were to read that out loud, you'd understand that those two words is probably a mistake. They probably mean the number 2 cycles, and has no impact on how the gene itself could be functioning. However, what if it matters? What if this mistake impacts how a gene is functioning, right? So if you have a cell should stop, I mean, it should be growing every 2 cycles, but suddenly the word is no longer intelligible. It's not a word the cell itself can read. And so, you know, there's normally other processes, if these DNA repair mechanisms fail, that will stop a cell, even with these problems, from continuing to grow. So we have things like things that are known as tumor suppressor genes that will detect the damage in many different ways. And there's lots of different, thankfully, fail safes that cells have that will start a process known as apoptosis that basically tells the cell, listen, I'm really sorry. Something has gone wrong. You're no longer going to function the way we need you to. We've got to take you out of commission. Or sometimes, if that doesn't work, our immune system does a really good job of also recognizing these damaged cells. So yeah, maybe the cell fail-safe mechanisms have all sort of, you know, gone to the wayside or no longer doing their job. The immune cell can come along, recognize that something's not right. Also, you know, the cell again, it's got to be taken out of commission. You might be a problem down the road. We can't have you ticking along. And so because of all of these things, you know, we develop cells that have mistakes that might skip some of these mechanisms, but we're normally pretty good. Our bodies are normally pretty good at making sure they don't progress to tumors and then to cancers. So, you know, all this happens. Why, in this case, do we develop cancers and mutations? Well, sometimes the cancers get smart and they're able to evade the immune system. Um, Or these mutations can also occur at specific genes. So genes that tell the cells to stop growing or promote growing. So if you think of things like a mutation you may have heard of is in KRAS. That's a really big one in pancreatic cancer. Up to like 90% of pancreatic cancers have a KRAS mutation. KRAS is an important part of a signaling pathway that tells cells to keep growing. So when KRAS, sort of acquires these mutations, they can promote cell growth, right? So now all of a sudden you have uncontrolled cell growth. Things like TP53, another big cancer mutation, a gene that's mutated in cancer we often hear about, is a gene that's really important for stopping cell growth. And so again, you sort of take that gene into commission, we're going to have uncontrolled cell growth. And so, losing these genes on larger scales along with the cancer cell finding ways to avoid the immune system, or the immune system not being able to recognize it until it's too late, can result in the development of tumor growth. And the thing is, it's not just one of these mutations that can cause this problem. It's that these mutations accumulate over time, right? So you might have one mutation, cell's fine, whatever, it's not going to actually develop into a cancer. But as these mutations, sort of group up and you get more and more of them, you get a tumor formed. And so again, that's why a lot of times you'll see cancer cells, in particular cancers, have specific, groupings of mutations associated with them that then lead to the disease. Again, like pancreatic cancer, you get things like KRAS, TP53, SMAD4, along with a lot of others that are sort of typically found within the cancer itself. And so again, if we revisit the quote that I pulled from the Cause website, pancreatic cancer is this abnormal growth of cells, that are out of control because of the loss of a lot of these really important mechanisms that stop the cells from growing, and then can lead to the development of malignant cells and malignant tumors. So, pancreatic cancer, like most cancers, is often thought of as one thing, right? We tend to sort of group cancer again as one big scary umbrella word. And then even within the cancer types themselves, break them down into just pancreatic cancer. But pancreatic cancer is not, a homogeneous thing. It's not just one thing. Pancreatic cancers can be broken up into many different ways. One of the ways in which it can be broken up is into whether it's an exocrine tumor or an endocrine tumor. So if we think back to my description of how the pancreas works, an exocrine tumor is associated with tumors forming in the parts of the pancreas that are really important for digestion. So as I said, those sort of like acinar areas, those ducts that transport the enzymes that are important for digestion, as well as endocrine tumors, which tend to grow, within the areas that are really important for that hormone production that I said we talked about in terms of blood sugar regulation within the body. These are much more rare, one, because obviously there's a lot fewer of those areas within the cells, within the tissue, sorry, as well as the fact that endocrine tumors, one being are found in the areas that are more prone to damage. Again, you get these digestive enzymes that are being formed and result potentially in more cell growth. So you're going to have more and more of these areas that have the sort of room and the potential to develop mutations that then can lead to tumors. So exocrine tumors tend to be more aggressive and they're almost always malignant, whereas endocrine tumors tend to be a little more, grow a little more slowly, and they're not always malignant. They can be benign. And so I'll just give a brief little introduction to some of the further tumor subtypes we can get within these two sort of breakdowns of pancreatic cancer. So the one that people tend to be most familiar with when it comes to pancreatic cancer is adenocarcinoma. Unsurprisingly, it's because it is the most common type of cancer of the pancreas. Most over 90% of pancreatic cancer patients will have an adenocarcinoma. And this originates in the pancreatic ducts. So again, if you think about, I talk about the sort of tube that runs through the pancreas itself that is really important for transporting these digestive enzymes that are produced by the acinar cells to the front of the small intestine. That's sort of where we'll see the origin of this cancer. Again, because this is a tissue that is frequently experiencing, these sort of potentially caustic, I guess, in one way, enzymes that it has to transport down. And so it is also known as pancreatic ductal adenocarcinoma. So you'll often see PDAC I tend to use that acronym a lot when talking about my research, for instance, because I study in particular adenocarcinoma. Um, and that is tends to be a lot of the focus of a lot of research for pancreatic cancer because it is so difficult to treat and it affects so many different patients. Along with adenocarcinoma, there are other exocrine tumors, but these tend to be very rare. So ones like acinar cell carcinoma, again, those cells that um, produce these digestive enzymes, and it can be associated with an increased production of lipase that could actually be detected in the blood of patients with it, as well as intraductal papillary mucinous neoplasms and mucinous cystic neoplasms that both begin in different parts of the pancreas, but again are very rare. Some of these, occur in like 1 to 3% of pancreatic cancer patients. Along with the exocrine tumors, we can also have, as I said, the endocrine tumors. These are rarer, occurring at about 5% of pancreatic cancer patients. And these occur again in those islet cells, so those cells that produce the hormones associated with blood sugar regulation. And they can be known as either hormone producing or non hormone producing. And the vast majority fall into this non functional islet cell tumor, non hormone producing category. But some can be associated with either an increased or decreased production of specific hormones. And these tumors, as I said, these sort of breakdown of endocrine versus exocrine tumors are different. They progress differently. They look different, and they can be sort of approached differently. Neuroendocrine tumors have a much higher chance of going for surgical resection versus like an adenocarcinoma, which is a relatively low chance depending on the stage at which it's diagnosed. And of course, as we know, pancreatic cancer tends to be diagnosed at a very late stage. And so, what are the treatment options for pancreatic cancer? Really, the best treatment option is really the surgical resection, but as I said, that's not available to a lot of patients. They don't really do surgical resection if you're at a later stage, 3 or 4, and again, because of that late stage diagnosis, most patients aren't able to receive upfront surgical resection. And so most of the current treatment options are focused on chemotherapy, which is normally done in a combined regimen with multiple chemotherapies. I know you guys will be having other talks throughout this process and having someone sort of give you a more in-depth explanation of how these which chemos regimens they are, how they work, and why we use them in the context of pancreatic cancer. So I won't go into like that too in depth today. But along with chemotherapy, you can also get radiation therapy normally in a sort of combined chemoradiation regimen that is used to target hopefully the tumor a little more specifically. Um, and so, as I said, pancreatic cancer is often diagnosed late, and so these treatment options, can be, and these regimens are really designed and with that in mind. And so, why does this happen? Why is it diagnosed so late? Why do we get to a point where so few patients are eligible for surgery, and a lot of these treatments end up, um, being more about extending the lifetime than being curative. Um, and so it's like if you see here, it's like a good like 50% are diagnosed at stage 4, which, as I said, is by the time the tumor has spread, it's metastasized, it's harder to treat. And so this is owing to a couple different factors. One really important one is the position of the pancreas in the body. So as I said at the very beginning of the talk, it's sort of tucked in amongst all your other organs. It's found behind the stomach, and it's a relatively small organ, really right in the middle of your body. And so it's not one of those things that, you think of things like breast cancer where you might, discover a lump, um, or a melanoma where you can, sort of see it grow. It can lead to earlier detection. Pancreatic cancer, like a lot of the sort of the GI abdominal cancers, unfortunately has that um, difficulty of being one of those things that until you present with symptoms, you often, won't diagnose it. And because of one, where the pancreas is, and two, how it functions, you often get late stage symptom presentation. Um, so, as I said, most of the pancreas is dedicated to producing the digestive enzymes, and we also have these islet cells that are spread throughout the pancreas itself. And so, if you were to develop a tumor in one part of the pancreas, a lot of times the other parts will sort of pick up the slack, and it won't be till till the cancer has started to impact the functioning of other organs, or really impacting the function of the pancreas with larger or more diffuse tumor spread, that you're going to get that symptom presentation. So along with that, you know, um, diagnosis of the pancreas can also be affected by where the tumor is within the pancreas. So cancers found at the head of the pancreas, for instance, tend to be diagnosed earlier because, that's where the pancreas and the pancreatic duct meets up with the bile duct and goes to the duodenum. So, that's where you're going to potentially see um, sort of an impact on the impact of the pancreas's functioning and some of those symptoms, versus if it was toward the end of the pancreas, toward the tail, where you sort of have the rest of the pancreas that can again pick up the slack and hide some of that deleterious symptoms that you would develop. Along with that, again, there is not a good routine screening for pancreatic cancer. So, again, for breast cancer, and for a lot of colorectal cancers, we can do routine screening. They're starting to look at routine screening for lung cancer, but unfortunately, with the pancreas, again, there are not a lot of good screening methods um, that we can use, and that's one of the focuses of research right now, is trying to identify some better ways that we can identify pancreatic cancer patients earlier. And so, how can we improve the early detection of pancreatic cancer? Um, so one is to know the symptoms, know the risk factors, and I'll go over those in a few minutes. And the other is, to really said to improve detection methods. So right now, a lot of detection methods rely on symptom presentation, and after that, using a lot of diagnostic tools to identify the tumor, so ultrasound, CT scans, MRIs. So potentially one, improving the detection through improving those methods. So if you're getting a scan for something else, maybe they can detect the tumor, as well as finding potential biomarkers. So one that we currently use in the clinic is CA19-9. It's just a carbohydrate antigen that's produced by pancreatic cancer cells, and so is produced more in pancreatic cancer patients. But that currently is, not necessarily the best detection method, because there's a lot of reasons your body can produce more CA19-9, um, as well as, sort of identifying, you talk about things like circulating tumor DNA and other detection methods that could potentially improve it. But right now, sort of our best method is to as I said, know the symptoms, know the risk factors, and monitor high risk individuals. And so, what are the symptoms of pancreatic cancer? Again, this is sort of an area I feel like you guys would know a lot more than me, and have a lot of more firsthand experience. But again, thinking back to the position of the pancreas within the body, a lot of symptoms are associated with abdominal and mid back pain. Again, remembering the pancreas is just right in front of the spine. And then things associated with the fact that the pancreas is losing its functioning. So unexplained weight loss, because our body's no longer processing its nutrients as well. Yellow skin or eyes when it starts to impact the liver, which of course is right next to it. Changes in urine output and stool. Again, new onset diabetes. Again, thinking of the pancreas and its important role in blood sugar regulation. Again, the digestive problems, or just mood changes. As you know your body, and sometimes when it's not feeling right, you're not feeling right. And so if you suddenly notice that, and this holds true for a lot of cancers, if you suddenly notice that your outlook or your mood itself has changed, or you find yourself being, tired all the time, or not having the energy to do things, that's often another good sign that something is amiss, and could be a symptom of pancreatic cancer. And so what are the risk factors? These are also really important, because if you fall into some of these categories, maybe you'll sort of be on the lookout for some of these symptoms. So smoking, which is associated with the increased risk of a lot of cancers, as well as obesity. And other things such as chronic pancreatitis and chronic diabetes, again, two things that can impact the sort of functioning of the pancreas, and impact, how healthy the cells of the pancreas are going to be, which again raises that risk for them to develop these mutations that can then develop into a cancer, as well as age. Older people do tend to develop pancreatic cancer, but it can be found in younger people as well, especially if they fall into some of these other risk factor categories, such as a familial history of pancreatic cancer. So this is again another big risk factor. And this can fall into a couple different a couple different sections. So if you know you have a couple first degree family members who develop it, or a first degree family member who develop it early, again raises the risk, as well as having an inherited genetic syndrome associated with pancreatic cancer, or a family history of some other cancers, such as breast, lung, and colon, that are associated with some of these genetic mutations that we see in pancreatic cancer. um, that can then lead to, so if you see them in other cancers, it may be a thing of it might not develop the same way in you, and it could lead to an increased risk of pancreatic cancer. And so, with that inherited genetic mutations, you can get things you hear a lot about BRCA1/2 gene mutations, as well as some illnesses that are associated with specific mutations, so things like Lynch syndrome, um, or things like cystic fibrosis, familial adenomatous polypsis. Sorry, some of these words are not ones I get to say very often, but they're again all associated with increased risks of developing illnesses of the pancreas that can then damage the pancreas itself and lead to pancreatic cancer. And again, if we think back to sort of my primer on how cancers develop, and you think about the heritability of cancers, and why this is such a big important risk factor, um, is the fact that a lot of these mutations are associated with those sort of spell checkers, as I said earlier, that helps make sure that the DNA repair process happens properly and that these mutations don't develop. So again, things like um, BRCA1/2, PAB2 are really important, as well as problems in the what is known as the mismatch repair system pathway that we see with Lynch syndrome. So again, if you sort of have these inherited potential damages in the spell check pathways, um, the DNA itself is going to rapidly require more mutations that can then lead to the development of cancer, as well as problems with tumor suppressor pathways, then like STK11 or TP53, that can also be associated with some of these heritable diseases that can then lead to pancreatic cancer. And so there are just some key takeaways from this talk. It's hopefully been somewhat informative, but again, this is sort of a quick primer that should help you guys with the next talks. So one, knowing where the pancreas is within the body and its important functioning. So they said the pancreas is important for digestion and blood sugar regulation. Um, Pancreatic cancer, as I said, occurs when cells acquire these mutations, these damages that lead to uncontrolled cell growth, and eventually develop into tumor formation. Um, and again, owing to where the pancreas is in the body and the sort of the roles it has, knowing the symptoms and the risk factors can help us detect the cancer sooner, which is really key in bringing down in early detection and helping with survival rates of patients. I will say, um, when I started my degree, 5 years ago, the 5-year overall survival rate of pancreatic cancer in Canada, I think, was just over, 5%. And even in those 5 years, we've brought it up to, I think, the last um, Canadian Cancer Report, it was up to over 10%. So part of that is into improved treatment regimens, which again, I'm sure you guys will hear about in the coming weeks, and the ways that we've really over the last um, that even in the last 5 years have really worked to try and make the outlook better for patients, as well as some of the other research is coming down the line, like things like immunotherapy, which is the focus of my project. Again, some of those things I'm sure you'll hear about in the coming weeks. But really, our biggest the biggest thing we can do is sort of spreading the awareness and helping others know the symptoms, know the risk factors, know if they could be within the high risk category, to help them sort of maybe identify that sooner, get the diagnosis they need, and then move on to the potential treatments. So thank you so much for your time. I hope this was informative and helpful. As I said, I'm not the expert of all experts on pancreatic cancer, but I'm really passionate about it. It is the area of my thesis. And I hope you guys can take away something from this talk that can help both with your understanding of cancer and then with your learning within this sort of course in this series. So thank you.
Thank you so much, Stacey. That was amazing. That was so good and such like a comprehensive overview. I know it can be hard sometimes to not go super deep, but like even like the thumb to the pinky thing I'm still thinking about. I've never heard that before, and I really love that. So thank you so much for your presentation. I know there were a couple questions that came through already in the chat. One thing I found is that through my endoscopic ultrasound is that my left kidney is in front of my spleen, partially blocking the end of my pancreas from regular scans. Question for when the presentation is done, why would chemo only be proposed instead of chemo and radiation? And I don't know if you're able to answer that, Stacey, or not.
Oh no, sorry. I didn't mean that only chemo would be proposed. It's often done with chemo and radiation. I just mean what I meant was if you are diagnosed at a later stage, surgery is often not an option, but they will typically do a chemo radiation regimen. And as I said, I believe you guys are getting a talk on that later on from an actual expert who would hopefully be able to answer a little more questions about why they choose the regimens they choose for, depending on sort of how your cancer is presenting. But no, they do typically do a combo of chemo radiation if possible. The only point I think when they wouldn't is if depending on like the health of the patient themselves, that's sort of how they make a lot of those decisions on whether or not they think they would be able to whether having the treatment itself, would cause more adverse effects than it would be worth trying with just one or the other. But again, not an expert who can say for certain why particular regimens are always chosen the way they're chosen.
Totally. And you said, does obesity really increase risk by 20 times? I don't know if you wanted to add anything to that.
And so it's 20 times versus uh, a non-obese person, and that was more to do with obesity is associated with a lot of inflammation. And so this is true for a lot of cancers where increased it all kind of this is why I kind of gave the talk about the how cells develop mutations. I know it's one of those things that can seem a little silly, but that's sort of what happens is like inflammation results in cells having to grow and divide more often because they're dying. And with inflammation, you can have an increased risk of mutation development. Um, obese patients, because of the inflammation associated with it, um, one can develop sort of these mutations more often. And two, I mean, honest, this is again, I'm not an expert. This is more of an opinion than anything else. But obese patients often, one, have different symptom presentation, and two, can have to like, I don't want to say fight harder to like have that diagnosis done. But if an obese patient comes in presenting with new early onset diabetes, like I don't know if pancreatic cancer is the first thing that physicians are always going to think of. And I think that partially has to do with us changing how we approach patients who fall into the obese category and taking some of their symptoms maybe a step further um, than they are currently being. Whereas if a patient who is an obese presents with diabetes and some other symptoms, they might go for those scans a little earlier. But again, that's me commenting more on how the medical um, practice handles different types of patients than the actual science, which is technically not what I'm here for. But that is probably another reason why you see an increased incidence with patients,
Really,
or
definitely.
an
Yeah.
increased, I should say, late stage diagnosis with obese patients.
Right. No, that totally makes sense. And yeah, I know it's definitely not, the symptoms can be so vague that it's often not the first thing that they jump to.
No.
Um, I said, why is the type of cancer so likely to recur?
So the thing with pancreatic cancer, and again, you'd have to talk more to a surgeon for this, but from my understanding, is pancreatic cancer tumors tend to be a bunch of small tumors that are more diffuse throughout the pancreas. So it can be harder to, I mean, it's often why when you do like a like a Whipple, I hate saying the actual, I have a hard time saying pancreas, um, the pancreas resection, they often have to take, the whole thing, sort of take a lot of the tissue around it, um, because it can be harder to do like just a tumor resection itself. And again, because of where the pancreas is within the body, a lot of times like it may have spread and metastasized to a point where like it's not quite detectable yet by our detection methods, but it will sort of recur that way, because again, it's pressing up a lot against a lot of these other organs, and it can be hard to get good, clean tumor margins. Um, and it's just a really aggressive cancer that, tends to, once it starts growing, grows pretty quickly.
Yeah, definitely. Are you aware of how much more likely it is for a person with a compromised immune system to develop PC?
I don't know. I don't know off the top of my head, but I mean, it holds true for a lot of cancers that people with a compromised immune system have an increased risk, but it also depends on how the immune system is compromised. But that is something they will monitor patients, for instance, who are on, have had a transplant or on like tumor anti-rejection drugs that will suppress the immune system because you don't have those immune cells sort of going around and monitoring, the rest of your system as much. But I don't know off the top of my head what the actual like incidence or numbers would be.
Okay, yeah, that makes sense. I think if obesity increases your risk 20 times, then it's a modifiable risk factor that the medical community really needs to promote. Any comment?
Okay, yeah, no, I can't really, I mean, I agree. I think it's something we should definitely be like looking into. There definitely should be research, not just in pancreatic cancer, in a lot of things and how obesity impacts them and how we can, sort of use that as something um, to really put patients on maybe a more high risk um, detection category where we monitor them more closely. But again, as someone who does, like, I'm not a medical professional. They don't let me touch patients. They just let me look at cells in a microscope. I can't speak to how that would actually be, implemented in a clinic or what that would mean, for physicians and actual medical practitioners.
Totally, totally. Sorry, Stacey. I know some of these questions are
No, I mean it's fair. That's like
yeah,
I can answer what I can, but
totally, totally really appreciate that. But hi, Stacey, one more. Can you have pancreatic cancer without elevated CA 19-9 levels?
yeah, for sure. That's one of the reasons why that detection marker is like we use it because it's the best we have, but it is by no means the best detection marker. Like you can have elevated levels and not have pancreatic cancer, and you can have pancreatic cancer and not have elevated levels. It's sort of the best we have right now, but it's sort of it's one of those ones that is not as reliable as we wish it would be in terms of monitoring detection for pancreatic cancer.
Right. Okay, great. Are there any more questions? Feel free to unmute yourself and ask or type them in the chat.
Oh, then it's actually kind of my research. So I'm looking at immunotherapy of pancreatic cancer. There are for sure a lot of things happening in clinical trials. The problem, but there's not a lot. So no immunotherapies right now are really being used um, for pancreatic cancer unless you have, no, not even, I shouldn't say that because it's not even if you have BRCA. They use a different chemo regimen. But pancreatic cancer has not shown a lot of current immunotherapy, sorry, have not shown a lot of promise so far with pancreatic cancer, but that's true of a lot of solid GI tumors. Um, but one of the problems with pancreatic cancer, depending on your cancer, is they tend to be what we call immune cold tumors. So they don't have a lot of immune cells infiltrating into them. And most of the current immunotherapies that are being used in clinic work well in immune hot tumors, the tumors that naturally have a lot of immune cells sort of kicking around. So a lot of the work being done right now in pancreatic cancer is trying to figure out how we can turn this cold tumor into a hot tumor, how we get immune cells into the tumor itself, and how we can make them very targeted to the pancreatic cancer. So there's definitely a lot happening both in the stuff I do. So I do a lot of preclinical work again. They just make me look down the microscope at the cells. But in a lot of clinical research as well, they're doing a lot to try and figure out how can we make the immune cells go to the tumor and then successfully target it. Um, but unfortunately, it's one of those things that I think we still have a little bit of a ways to go. But there's a lot being done. I've sat through a lot of talks even in the last year. It's funny when I started my PhD again, pancreatic cancer was just sort of becoming the new hot cancer to study, and even the 5 years I've been here, there's been a lot more. I find there's a lot more research coming out in the context of immunotherapy and pancreatic cancer. So hopefully within the next little bit, we'll see really good headway being made. There's some promising stuff coming out, but it's not quite there yet. That's actually good to know. And I feel like we're seeing that more and more where doctors are sort of taking the initiative to do it, but it's not part of the standard treatment. in the way it is for a lot of cancers. But that's actually I haven't seen that being reported a lot, but that's actually good to hear. I was gonna say cancer can be, we say smart, but I mean like it's not thinking. It's not smart in the way we're smart.
Does anybody have any other questions for Stacy?
I don't know if I can expand upon it apart from saying that I think a lot of these sort of correlations between mutations in specific parts of these DNA repair pathways, and how it develops in cancer is sort of an ongoing process. And like I'm not an expert on any particular one. That's not what my area of study is. But a lot of times it's depending on one, where the mutation is, and like whether how the mutation impacts how the protein and or gene works is a really big factor. And PALP2 may be one that on its own isn't necessarily going to lead to cancer, but having it along with other things um, they can often be like a combined, development of mutations being a problem. Um, but I've it's one of those things that over the last I find even again last couple of years we've been finding more and more of cancers associated with specific mutations in these different parts of the DNA repair pathways. I don't know for certain, but I would say yes. So a lot of times any sort of pathology associated with, I mean, any tissue, but the pancreas in general, that's why things like pancreatitis and stuff are also associated with the development of cancer. So if, for some reason or another your pancreas is developing cysts, that may be indicative that there's something else maybe not quite right. So it might not be a thing of like, oh, if you have cysts, you're going to develop pancreatic cancer, as they can often be benign. But because you have this thing developing, there is the chance that, all it needs is the flip of one switch instead of four, for something to develop into a cancerous tissue. But I don't know, again, like I don't know off top what the actual like numbers would be of, if you have cysts, your incidence goes up this much. I don't know of any. I don't know of any that are linked to cysts in particular. Um, there may be, but again, with pancreatic cancer, it tends, like I said, most tend to be KRAS, um, and then things like SMAD4 and TP53. But I don't know if like any of those sort of like highline mutations or any of the DNA damage repair mutations are associated with cysts particularly.
Unfortunately, still one of the biggest risk factors is lack of knowledge in the medical community. For example, no jaundice or diabetes equals no pancreas cancer, no mutation equals no pancreas cancer, no elevated lipase equals no pancreas cancer. I know very few pancreas cancer patients discovered diagnosis via jaundice or sudden onset diabetes. Oh, and she said, I meant to say no one of numerous patients via jaundice or diabetes.
Yeah, I mean that's sort of the biggest problem with pancreatic cancer right now is it's so hard to detect unless you are presenting with, a bunch of symptoms. And in some cases, unless you're really sort of, pushing for things to be looked at. Again, this is just anecdotal since from talking with different patients through Craig's Cause, where it's a case of a lot of times you have to keep going back and going, no, like this is not, I'm not feeling right. Because things like, presenting with diabetes, again, because it tends to be older populations who develop pancreatic cancer, older populations also just tend to develop diabetes over time, right? And so that and back pain, again, you think what are symptoms associated with getting older? Back pain. And so It's not normally unless it's really severe or it's in combination with a bunch of symptoms that, they'll sort of jump to potentially pancreatic cancer. Hopefully, I think that's been changing. Again, I feel like you'd have to talk to sort of physicians and doctors, but I think there's been a big push within that community to start asking that question when patients present with these symptoms in the hopes of like, well, if there's nothing there, there's nothing there, but if there is, we'll catch it early. Um, but again, they don't let me really see the patient, so I don't really have that perspective, unfortunately.
Carolyn said, is a person diagnosed with pancreatic cancer at higher risk of getting other cancers?
Um, so I don't, you mean you have like, you end up with mutations, but I don't think it's one of those things of like, I mean, yes and no. So if you're at higher risk of developing pancreatic cancer, yes, you're also at higher risk of developing other cancers because, if you have a BRCA1/2 mutation, you're also at a higher risk of developing things like breast cancer, um, or ovarian cancer, if you're female. Again, if you're a smoker, you have a higher risk of developing a whole lot of cancers. So like not the pancreatic cancer itself is not necessarily the reason you're at a higher risk, but a lot of the things that lead to you developing pancreatic cancer or being at a higher risk of developing pancreatic cancer mean that you're also at a higher risk of developing other cancers.
Definitely. Okay, that's good to know. Um, sorry, just reading this here. Okay. Are there any other questions for Stacy? A great discussion here today. We did create a little quiz. So the plan is everybody who completes all 10 of the modules will receive a Craig's Cause sweater at the end of this. So in order to complete the module, you would just need to obviously watch the video either live or recorded and then just complete the quiz. Once you complete the quiz, we'll send out certificates of completion to everyone. Just so that you have that. And then at the end, everyone who completes all 10 of the modules will get a little Craig's Cause sweater, a hoodie, just as a way of sort of celebrating you and doing this program. So the quiz that we have for today, I'm going to send it around very shortly. The questions are all things that Stacy hit on today. So should be reasonably, I don't want to say easy, but should be reasonably uh, uh,
Straightforward.
straightforward. There we go. That's the right word. Thank you, Stacy. But if anybody does have any questions, please feel free to send me an email, and I'm happy to help. And also, I just want to say that we're not looking for 100% accuracy or anything like that. It's nothing like that. It's just to go back in and sort of test your knowledge and just make sure that you have a good understanding of the information. And then if you have any questions, please do feel free to reach out.
Again, I can only speculate. I'm not an oncologist. I don't follow, I don't make those decisions and I don't, necessarily know a lot in terms of like why they make those decisions, but if your cancer is being managed by the treatments you have, it may be a case of sometimes the cure is worse than the disease when it comes to some of these chemos. Some of them are really harsh. Some of them can have really bad symptoms associated with it. But if, you're following along with this series, this may be a case of something one of the oncologists might be able to give you a little more insight into. But that would be my only speculation.
Hey everybody, well thank you so much for coming out today. Stacy, thank you so much for your time today and for all of your knowledge. This was a really great conversation, a really great like comprehensive overview like I said. I think it was really helpful and really insightful. So thank you so much for your time today. Everybody, if you need anything, please feel free to email me. It's Erin@craigscause.ca, ERIN at craigscause.ca. If you have any questions for Stacy, let me know and I'm happy to along to her. And otherwise, thank you so much, everybody. Enjoy the rest of your weekend. Sorry.